Thank you very much. Thank you to Lean for organizing this really nice meeting, and thank you also to the organizing committee for inviting me. It's a great honor to speak here. I'm a cardiac anesthetist and I work in South London, and I'm going to talk about, before I start to talk about cerebral autoregulation during bypass and potential reversible causes, I want to talk a little bit about outcomes in cardiac surgery. What do we actually measure for neurological outcomes and the clinical manifestations? In the UK, the Euroscore predicted outcome is regularly monitored, and as we know, patients get older. This is the increased Euroscore over the last 10 years. They have more multi-morbidities. Diabetes is more prevalent. However, the mortality itself, despite these high-risk patients, has reduced dramatically. And last year there was a paper published comparing the influence on this mortality between anesthetists and surgeons, and it basically showed that for anesthetists, and this is corrected to surgeon and center, each anesthetist is one line in this comparison, that there's basically no influence on the probability of in-hospital death. It's a straight line. Every anesthetist does similar work. In contrast, the surgeon's influence on this outcome is more dramatic, and this is corrected to anesthetist and center, and it depends a little bit more. It's not a big change, but a little bit more on the type of surgeon with regards to in-hospital death. So anesthetists do not appear to affect mortality. That was the conclusion from this paper. Does this mean that we can actually lie back and be happy? There was an editorial in the same edition, and that clearly stated that mortality is one outcome, but we also have to look at morbidity, and what anesthetists and the other team members in cardiac surgery should be measured on is also incidence of postoperative acute kidney injury, postoperative myocardial infarction, and last but not least, postoperative acute brain injury, which is very often manifested as delirium, showing acute hypoxia perioperatively, and delirium occurs up to 46% in cardiac surgery. What is the relevance of these cerebral injuries? And this is within the motto of this session. At the end, it's not the years in your life that count, it's a life in your years. The incidence of delirium is up to 46% in cardiac surgery. It's very frequent, and patients have longer hospital stays. The delirium increases the costs, and the 6 months and 1 year mortality is increased with delirium. And in addition to that, it's also associated with long-term cognitive impairment. Cognitive impairment, again, is very frequent, and this is a very nice review about cognitive impairment in cardiac surgery. However, it's often reversible, and if the outcome is good in cardiac surgery, if there's very little comorbidity and or if there's very little postoperative complications, then it can actually change into postoperative cognitive improvement. Is neurological outcome correlated to the usage of bypass or not? This has been investigated in this trial amongst other outcomes, and it clearly showed that there's no difference between, this was investigated in about 5,000 patients, no difference in postoperative stroke. And in a subgroup of patients, there was a subgroup of about 2,800 patients. There was neurological outcome assessed with different postoperative tests, and there was again no difference whatsoever between the on-pump and off-pump group. However, there was one test which was performed in hospital before discharged, but the outcome of this was completely reversed. And cognitive impairment and cardiopulmonary bypass was investigated in this study from Edinburgh, and it in 2,400 patients, and the conclusion again was that cardiopulmonary bypass may not be associated with cognitive decline. There are other lesions which don't induce clinical symptoms, and these have been reviewed recently in this paper. They can be seen on MRI scans, and they mainly show hypoperfusion in quite clearly defined areas here. And interestingly, they occur in up to 25 to 50% of patients. They are not necessarily related to postoperative cognitive dysfunction, which might show that postoperative cognitive dysfunction is not a very specific clinical outcome. And they are also not necessarily related to the procedure. They occur on pump, off pump, bypass surgery, and also after valve surgery. How about cerebral autoregulation during cardiopulmonary bypass? You are all aware that it is very well maintained, independent of the mean arterial blood pressure. And the reason for this is that there are very little energy storages in the brain, very little glucose and very little ATP, and because of this, the cerebral perfusion has to be maintained. It is not very much influenced by other variables except for PaCO2, where there's a linear relationship, and also with higher intracranial pressures, the cerebral blood flow will be reduced. And here again, you see that there aren't very many factors influencing the cerebral blood flow. Also, the cerebral blood flow is influenced by the cerebral oxygen consumption. So if there's very little metabolic activity in some areas of the brain, there would be vasoconstriction and less cerebral blood flow here. It is linear dependent from the temperature, and you see that here there's a linear correlation, and the cerebral metabolic rate is also reduced if you reduce the temperature. So with reduced temperature, there is a cerebral protection happening. How about the anesthesia? What is the influence of opioids on anesthesia? Again, they reduce cerebral blood flow, they reduce the metabolic rate, and cerebral autoregulation is maintained. Similarly with propofol, and relating to the discussion whether we should use propofol or isoflurane anesthesia, they have more or less the same effect. Cerebral autoregulation is maintained in lower doses of isoflurane. There's a strong reduction of cerebral metabolic rate with the isoflurane, and however, there's a slightly increased mild vasodilatation. And again, here, if we measure cerebral blood flow during cardiopulmonary bypass, it is not there's not much change with the pump flow, and again, there's not much change with the mean arterial pressure. However, cardiopulmonary bypass is associated with periods of low systemic flow, reduced hemoglobin, also with changing cerebral metabolic demands, especially when we rewarm, and we have perioperative patient and operative factors with high blood pressure, where we would expect to have higher mean arterial pressures in order to maintain the cerebral blood flow, and patients who are diabetic and who have old age. So how do we define what actually is the lower limit of autoregulation with regards to cerebral blood flow? And this was addressed by Professor Hawkes' group in America, and they assessed the lower limit of cerebral autoregulation in 230 patients undergoing CABG or valve surgery. They used transcranial Doppler measurements and regional cerebral saturation measurements in correlation with the mean arterial blood pressure, and with that they could measure whether there was the cerebral autoregulation was intact or not. And they described that the lower limit of autoregulation had a mean of 66 millimeters of mercury, but that there was a large range between 43 and 90 millimeters of mercury, and no correlation between preoperative mean arterial pressure and lower limit of autoregulation. So they proposed to monitor real-time individual lower limits of autoregulation with the technique that they used, which at the moment is not possible. But we have to be aware that there's a large difference. And in addition to that, they also measured found out that in 20% of patients undergoing cardiac surgery, there is impaired autoregulation during cardiopulmonary bypass, and in the subgroup of patients, there's a higher incidence of stroke. So what do we do? Do we run the cardiopulmonary bypass machine with lower blood pressures, or with higher pressures? And that has been investigated only in 3 trials. The first one, I skipped these slides. The first one was almost 20 years ago, where this was compared, and this study didn't show much difference between mean arterial pressures of 50 to 60 and 80 to 100. So where there was no difference in individual neurological outcomes, however, there was a difference in combined outcomes. Similarly, here in 400 patients, mean arterial pressure between 80 millimeters of mercury was compared to a customized mean arterial pressure according to the preoperative patient blood pressure of the patients, and there was no difference with regards to neurological or cognitive outcomes. This study showed positive results comparing mean arterial blood pressures between 80 and 90 and 60 to 70, and however, the positive results were only shown within 48 hours after the surgery, and there was unfortunately no longer-term follow-up. At the moment, there is a perfusion pressure cerebral infarct trial taking place in Scandinavia, and the outcome of this trial, the hypothesis states that a mean arterial pressure between 70 and 80 with a fixed blood flow during cardiopulmonary bypass reduces MRI scan evaluated brain injury, which appears to be quite an objective outcome in comparison to a mean arterial pressure of 40 to 50 millimeters of mercury, and we are awaiting the results of this, this would be probably contributing to the discussion whether we can improve cerebral lesions with changing the blood pressure. How about reversible causes of cerebral injury? With goal-directed perfusion, everything is done to optimize the oxygen delivery. And at the anesthetic end, we can actually measure as you know, the regional cerebral oximetry. So we can measure the outcome of optimal oxygenation of the blood and see whether the brain is well perfused. It has been shown in many studies that cerebral oxygen desaturation predicts cognitive decline and longer hospital stay after cardiac surgery, but it has so far, until very recently, not been really clear if we improve or if we can improve desaturations of cerebral oximetry. And this has been addressed by 2 recent studies where optimization of regional cerebral oxygenation was attempted. This is based on the finding that cerebral oxygenation desaturation during cardiac surgery has been associated with adverse perioperative outcomes. And in this study, an interventional algorithm was introduced, and which looks more complicated than it actually is. It includes steps to optimize regional cerebral oxygenation by optimizing the head position, optimizing mean arterial pressure, systemic oxygen saturations, and to also consider blood cell transfusions. And the conclusion was that in the majority of patients, over 90%, the desaturation, cerebral desaturations could be reversed, and consequently saturation was far better preserved in patients randomized into the intervention. And this very similar study had similar outcomes, and in this study the intervention included again to treat hypotension, also to increase, to normalize the cardiopulmonary bypass blood flow, to do blood transfusions, and to deepen anesthesia. In addition to cerebral oximetry, we also have the non-invasive depth of anesthesia monitor, which interestingly has been shown, if we use it in non-cardiac patients or non-cardiac anesthesia, to improve postoperative cognitive dysfunction. And this is due to the fact, not only because this monitor is not only used to avoid awareness during anesthesia, but also to avoid too deep anesthesia. So if we use this monitor, we avoid marked hypotension, which then might reduce the oxygenation of the brain. And it has been shown in non-cardiac surgery here in about 1,000 elderly patients that BIS-guided anesthesia decreases postoperative delirium and cognitive decline. And here in another larger study that again it decreases postoperative delirium. So our approach was in our hospital to use both monitors and to look at the neurological outcome, to use cerebral oxygenation, but also depth of anesthesia monitor. And we could show in non-cardiac surgery that monitoring depth of anesthesia and cerebral oxygenation and having interventional algorithms does reduce postoperative cognitive impairment. And we are currently conducting a pilot study in cardiac surgery with the same question: if we use multimodal cerebral monitoring and multimodal interventions to optimize cerebral perfusion, whether the neurological outcome will be changed. And we include only elderly patients and in this study. And during the procedure, the blinded group is still monitored with these monitors. So we have the results of the traces, and the intervention group receives treatment in order to reduce cerebral desaturations and to keep the depth of anesthesia at a level at around which is not too deep and not too light. We have randomized 88 patients, and this is an example of the traces that we get. The green line is the depth of anesthesia, and the red line is the cerebral saturation monitoring. And here you see this is an intervention patient where the depth of anesthesia is kept nice at around 50, but there is, despite that, there is some desaturation here, which is then treated and tried to be reversed. Interesting, our preliminary results show that the depth of anesthesia in the treatment group is actually higher, and so we could avoid potentially too deep anesthesia and too much hypotension. And we also showed that there was significantly less desaturation, cerebral desaturation, in the group of patients who were in the treatment group. And we could see that the treatment group had a significantly reduced incidence of postoperative delirium. So, to conclude, outcome results in cardiac surgery are heterogeneous. There's a low incidence of hospital mortality, however, higher incidence of cerebral morbidity. Cerebral infarctions are commonly ischemic and are secondary either to focal hypoperfusion or due to emboli or global hypoperfusion. There are inter-individual differences between the lower limit of the autoregulation, and the question still remains whether higher mean arterial pressures improve cerebral perfusion and clinical outcome. And there are reversible causes of cerebral injury which we can treat with the help of multimodal interventions and multimodal cerebral monitoring. Thank you very much.